The Recovery Kernel Substance-Specific Navigation Series. How to recover from PCP. Using the Recovery Kernel Framework. PCP, phencyclidine, angel dust, wet, sherm, embalming fluid, rocket fuel, supergrass, hog, boat. Warning: harm reduction resource, not medical advice. Crisis, call 911 or text 988. PCP intoxication is a medical emergency. Agitation plus pain insensitivity plus psychosis is the specific clinical picture. Call 911. PCP psychosis can persist for weeks after the last dose. If symptoms do not clear in 48 hours, psychiatric evaluation. The compendium names CYP2B6 as the dissociative logjam gene. PCP is its most clinically dangerous substrate. A note before you begin. PCP, phencyclidine, is the most pharmacologically complex substance in this guide series. Every other dissociative covered here, ketamine, DXM, nitrous oxide, operates primarily through a single dominant mechanism. PCP operates through 4 simultaneously, and the specific combination of those 4 produces a clinical picture that has no equivalent in any other substance of misuse. NMDA receptor antagonism so potent that it rivals surgical anesthesia at high doses. Dopamine reuptake inhibition producing stimulant arousal and agitation. Sigma-1 receptor agonism producing the specific perceptual alterations unique to this compound class. Muscarinic acetylcholine antagonism producing the anticholinergic features, dry mouth, elevated heart rate, urinary retention, hyperthermia, that compound the other 3. The result, a person who is simultaneously profoundly disconnected from reality, NMDA, highly aroused and potentially agitated, dopaminergic, experiencing perceptual phenomena unlike any other class, sigma-1, and physiologically stressed by anticholinergic load. This combination, dissociation and stimulation together, pain insensitivity and high arousal together, is what produces the specific and genuinely dangerous behavioral picture of PCP intoxication that no framework built for any other substance adequately addresses. The Recovery Kernel compendium names CYP2B6 as the dissociative logjam risk gene. PCP is the most clinically consequential substrate for this gene in common substance misuse. A CYP2B6 poor metabolizer encountering PCP is entering a pharmacokinetic situation where the most potent commonly used NMDA antagonist known cannot be cleared, accumulating at the receptor, extending and deepening both the dissociation and the psychosis beyond anything the person's dose would produce in a normal metabolizer. This guide addresses PCP recovery specifically. The ketamine guide in this series addresses adjacent territory, the NMDA antagonist recovery framework, the glutamate rebound, the dissociative natural porting architecture. Read it alongside this guide for the NMDA dimension. What this guide adds is what makes PCP specifically different from ketamine: the dopaminergic stimulant component, the anticholinergic load, the extended duration, the dramatically higher psychosis liability, and the specific clinical and community context that has made PCP one of the most misunderstood substances in addiction medicine. Section 0, Immediate Safety, the PCP Intoxication Emergency. Warning: the specific clinical picture of PCP intoxication, stimulant agitation plus NMDA pain insensitivity plus dissociative psychosis, is uniquely dangerous. Standard approaches to managing intoxicated individuals do not apply. Read this section before anything else. 0.1 Recognizing PCP intoxication. Classical building the centurion, the 4 signs that together point to PCP, not any other substance. PCP intoxication produces a specific combination that distinguishes it from stimulant intoxication, opioid overdose, and pure dissociative states. 0.2 The emergency response protocol. Warning: do not attempt to physically restrain a PCP-intoxicated person aggressively. The catecholamine surge from forcible restraint produces hyperthermia and cardiac risk on the already stressed cardiovascular system. This has resulted in deaths. 0.3 The prolonged psychosis warning. Warning: PCP psychosis can persist for days to weeks after the last dose, far longer than any other non-psychedelic substance in this guide series. This is not still high. It is a specific neurobiological state requiring clinical management. PCP's slow dissociation from the NMDA receptor, combined with its lipophilicity, stored in body fat and slowly released, produces psychotic symptoms that persist long after the drug has cleared plasma. For CYP2B6 poor metabolizers, the accumulation problem extends this further. The clinical picture can meet DSM-5 criteria for a brief psychotic disorder, schizophreniform disorder, or even schizophrenia during the active phase, none of which it is. If psychosis does not substantially resolve within 48 hours of last PCP use, psychiatric evaluation is required. Prolonged PCP psychosis is a medical condition, not a recovery state. Antipsychotic medication is the indicated treatment for prolonged PCP psychosis, risperidone, olanzapine, or quetiapine. Do not wait to see if it resolves without treatment. Each day of untreated psychosis carries its own risks. Inform the treating psychiatrist specifically, this is PCP-induced psychosis, not primary psychosis. The treatment and prognosis are different. PCP psychosis resolves with sustained abstinence in most cases, primary schizophrenia does not. This distinction affects both immediate medication decisions and long-term management. Sleep is the most powerful non-pharmacological intervention for PCP psychosis. Inducing sleep through benzodiazepines or quetiapine often produces dramatic improvement upon waking. 0.4 What is actually in wet/SHRM, the adulteration problem. Classical building the centurion, the urban legend versus the pharmacology. Embalming fluid is the delivery vehicle, not the drug. Wet or SHRM, cannabis or tobacco cigarettes dipped in a liquid and dried, is the most common contemporary PCP use method. The name embalming fluid has generated a persistent urban legend that the cigarette is dipped in formaldehyde. This is incorrect as the active pharmacology. The liquid is either pure PCP in solution or PCP dissolved in an organic solvent, sometimes including real embalming fluid as the solvent base. The clinical implications. Formaldehyde, if present as a solvent component, adds pulmonary and systemic toxicity on top of PCP's pharmacological effects, making the combination more dangerous than PCP alone. The PCP concentration in wet cigarettes is entirely variable, there is no standardized dose. What feels like one hit can contain dramatically different amounts of PCP depending on the preparation. Street verification, there is no reliable field test for PCP in wet cigarettes. The DANCE-safe/reagent testing approach, marquee reagent turns pink-orange with PCP, can identify PCP's presence but not concentration. What is sold as wet/SHRM frequently contains other substances, ketamine, PCP analogs, PCE, TCP, PCC, or no PCP at all. Section 1. What PCP did to your brain. Classical building the centurion, the only widely used substance that is simultaneously a powerful dissociative and a powerful stimulant. PCP was developed in the 1950s as a general anesthetic, marketed as Cernal, an agent that produced surgical anesthesia through dissociation rather than unconsciousness. Its use was discontinued in humans because too many patients experienced severe emergence reactions, profound agitation, hallucinations, and delirium upon waking. These are identical to the effects that make it a drug of misuse. Its veterinary use, as Cernalin, continued because animals do not have the same post-dissociative emergence reaction. It remains in use today as a large animal veterinary anesthetic under the name Rompun, weight, that is xylazine. PCP is rarely used veterinarily now. Its primary contemporary existence is as an illicit substance. What makes PCP pharmacologically unique across the entire landscape of substances of misuse is the specific combination of receptor targets it activates simultaneously. 1.1 The 4-receptor architecture. 1.2 PCP versus ketamine, the clinical differences that matter for recovery. Classical building the centurion, same NMDA mechanism. Completely different clinical picture. 1.3, the PCP psychosis model, why this matters for recovery. Classical building the centurion, the brain on PCP is the closest available model of schizophrenia. Recovery requires understanding this. Since the 1960s, PCP has been recognized as the most pharmacologically valid model of schizophrenia available to researchers. Amphetamine psychosis produces positive symptoms, hallucinations, paranoid delusions, but not the negative symptoms, emotional blunting, poverty of thought, social withdrawal, that characterize schizophrenia's full clinical picture. PCP produces both. This is not merely interesting neuroscience. It has direct recovery implications. PCP psychosis requires antipsychotic treatment, not just abstinence. Waiting for it to resolve without treatment is both uncomfortable and carries its own risks from the agitated and self-endangering behavior it produces. PCP psychosis can be misdiagnosed as schizophrenia. A first-episode psychosis presentation in a young person whose history includes PCP use should always consider PCP as a causative factor before diagnosing a primary psychotic disorder. Urine drug screens may be negative by the time of psychiatric evaluation. PCP is detectable for 30+ days depending on use pattern, but clinical presentation may occur early in this window. The negative symptoms of PCP psychosis: emotional blunting, withdrawal, cognitive poverty, decreased motivation, look and feel like depression to the person experiencing them and to clinicians not considering PCP. This can result in incorrect treatment, antidepressants for PCP psychosis negative symptoms, when antipsychotics and abstinence are the indicated interventions. For heavy, long-term PCP users, a persistent deficit state may be present even after psychosis resolves, the cumulative NMDA antagonism producing lasting changes in prefrontal cortex function. This is the PCP-induced cognitive impairment that may require extended support and is addressed in Section 4. 1.4, what PCP was providing, the signal. The compendium C, 37 substance masking analysis, every substance preference is a signal. PCP's 4-receptor profile means it was providing multiple things simultaneously. 1.5, duration, metabolism, and the lipophilicity problem. PCP is highly lipophilic, it dissolves readily into fatty tissue and distributes extensively throughout the body. This produces several clinically important pharmacokinetic features. Long half-life, PCP has a plasma half-life of 7 to 46 hours, highly variable depending on CYP2B6/CYP3A4/CYP2C19 metabolizer status and urine pH. The long half-life compounds the extended duration of effects. Urine pH effect, PCP is excreted in urine in a pH-dependent manner. Acidic urine dramatically increases PCP excretion. This was historically used in emergency management, ammonium chloride to acidify urine and accelerate PCP clearance, but is now rarely practiced due to complications. Fat tissue storage, PCP accumulates in adipose tissue during heavy use. During periods of fat mobilization, exercise, caloric restriction, illness, stored PCP is released into the bloodstream. This can produce unexpected re-emergence of PCP effects, including psychotic symptoms, days or weeks after apparent cessation. The compendium names this phenomenon in the ketamine phantom smell section. The body is literally processing residue that was stored in fat tissue during active use. Urinary detection, PCP is detectable in urine for 7 days in occasional users and up to 30+ days in heavy users, with some cases of positive tests at 4 to 6 weeks after last use due to fat tissue release. Section 2, your genomic blueprint. PCP has a pharmacogenomic profile that combines the dissociative logjam risk, CYP2B6, named in the compendium with the dopaminergic stimulant genetics, COMT, DRD2, DAT1, and the psychosis risk profile, COMT, DRD2, that the stimulant guides identify. It is the most genetically complex recovery profile of any single substance in this series. Phenotyping without testing. Were PCP effects consistently more intense, more prolonged, or more psychotically severe than others at the same dose? CYP2B66/6 poor metabolizer very likely. The dissociative logjam, PCP accumulating without adequate clearance. Did psychosis or confusion persist for days after the last use? CYP2B6 poor metabolizer status or fat tissue storage releasing PCP during fat mobilization, or both. Was the primary pull of PCP the stimulant intensity rather than the dissociation? Warrior COMT constitution plus DRD2A1 reward deficiency syndrome. Stimulant recovery architecture is the primary natural porting target. Was the primary pull the escape, the disconnection, the pain relief? NMDA dissociative architecture is the primary target. Contemplative and trauma processing framework. Did PCP make you feel calm or right in a way that other stimulants didn't? Possible SAGE COMT profile finding in PCP's NMDA quieting of the overactive prefrontal system, the relief the SAGE's overloaded catecholamine system could not otherwise access. Also the highest psychosis risk profile. Section 3, Medical Management, what PCP recovery requires clinically. Classical building the centurion, PCP recovery has medical dimensions that other dissociatives do not, because of the prolonged psychosis risk. Unlike ketamine recovery or DXM recovery, where medical intervention in early cessation is rarely required beyond the standard supplement and behavioral protocol, PCP recovery has a specific medical dimension, the management of prolonged PCP psychosis. This requires clinical partnership that most other guides in this series do not. 3.1 Managing prolonged PCP psychosis. 3.2 Having the physician conversation. PCP use disorder is poorly known among general practitioners and even many addiction medicine specialists. The clinical framing that produces appropriate response. I have a history of phencyclidine, PCP, use disorder. PCP is a potent NMDA antagonist with additional dopamine reuptake inhibition, sigma-1 agonism, and muscarinic antagonism. I may have CYP2B6 poor metabolizer status based on my response to the drug. I am currently experiencing symptom. I am requesting CYP2B6 and CYP3A4 metabolizer testing. I am also requesting evaluation for PCP-induced cognitive impairment and psychosis management/sleep support/other, through appropriate pharmacological management. The physician who does not know about the CYP2B6 dissociative logjam needs to know about it, not only for current management but because CYP2B6 metabolizer status affects the safety of several medications they may prescribe, efavirenz for HIV, bupropion for depression or smoking cessation, cyclophosphamide if oncological treatment is ever needed. 3.3 No FDA-approved MAT for PCP. Like cocaine, methamphetamine, and DXM, PCP has no FDA-approved medication-assisted treatment. The pharmacological support for PCP recovery is antipsychotics for prolonged psychosis, as above, not MAT, but specific medical management. Benzodiazepines for acute anxiety and sleep disruption in early cessation, short-term only, addiction risk in this population. Non-stimulant ADHD treatment, atomoxetine, guanfacine, if ADHD co-occurs, the DAT-mediated stimulant component of PCP may have been self-medicating. Depression treatment, the negative symptom presentation distinguishes from serotonergic depression, identify which dimension is dominant before selecting treatment. 5 MTHF first for MTHFR variants. Section 4, Biological Reconstruction. PCP biological reconstruction combines 3 parallel tracks: 1. NMDA glutamate system normalization, ketamine/DXM guide framework; 2. Dopaminergic stimulant system reconstruction, cocaine/meth guide framework; and 3. Acetylcholine system support for the anticholinergic component. The methylation foundation underlies all 3. 4.1 The methylation foundation. 4.2 NMDA glutamate system normalization. NAC, 600 to 1,800 mg daily, divided, with food glutamate homeostasis in the nucleus accumbens. Multiple mechanisms relevant to PCP recovery, craving reduction, antioxidant, and direct glutamate modulation. Begin day 1. The most multifunctional supplement for PCP recovery. L-theanine, 200 to 400 mg, morning and evening NMDA receptor glycine site modulation, anxiolytic, alpha wave promotion. Addresses the cognitive hyperactivity of NMDA rebound. Glycine, 3,5-G, evening NMDA coagonist supporting receptor normalization during recovery. The ketamine guides glycine rationale applies, supporting some NMDA activity helps the receptor system normalize after chronic antagonism. Omega-3-DHA2 4G daily neuronal membrane support for NMDA receptor environment, anti-neuroinflammatory. The most persistent source of neuroinflammation in PCP recovery is the prolonged NMDA antagonism and the oxidative stress of heavy PCP use. 4.3 Dopaminergic stimulant system reconstruction. L-tyrosine, 500 to 2,000 mg, morning, away from protein dopamine precursor for the DAT inhibition component of PCP. The same primary reconstruction supplement as cocaine and meth recovery. Brain stack, uridine, 250 mg, plus DHA, 1G, plus CDP choline, 250 mg D1/D2 receptor density upregulation. The most important structural recovery target for the DRD2A1 reward deficiency syndrome that PCP was feeding through its dopaminergic component. Takes weeks to months, begin day 1. Rhodiola rosea, 300 mg, morning dopamine and serotonin modulation, adaptogenic anti-fatigue. Particularly useful in weeks 2 to 8 when the dopaminergic deficit produces the gray quality of early stimulant recovery. 4.4 Acetylcholine system support. Classical building the centurion, the anticholinergic component requires its own recovery track. PCP's muscarinic acetylcholine antagonism is an aspect of PCP recovery that no other guide in this series addresses, because no other substance has this combination. The sustained anticholinergic load of chronic PCP use produces cognitive effects, impaired memory, impaired attention, and the dry/anhydrotic peripheral effects through the acetylcholine system. Recovery requires supporting this system back to baseline. Alpha-GPC, 300 to 600 mg morning, the most bioavailable acetylcholine precursor. Directly provides the choline needed for acetylcholine synthesis. Particularly important for memory and cognitive recovery from PCP's anticholinergic burden. The compendium identifies alpha-GPC as a primary supplement in the cognitive recovery stack. CDP choline, 250 mg, morning, already in the brain stack above dual function, dopamine D2 upregulation and acetylcholine precursor. The combination with alpha-GPC provides comprehensive cholinergic support. Huperzine A, 50 to 100 micrograms, with physician guidance acetylcholinesterase inhibitor, prevents the breakdown of available acetylcholine. Should not be combined at high doses with alpha-GPC and CDP choline as the combined cholinergic effect may be excessive. Use one high-dose approach or low-dose combinations. Lion's mane mushroom, 500 to 1,000 mg daily BDNF and NGF stimulation, the compendium names it specifically for NGF support. NGF, nerve growth factor, is required for cholinergic neuron health. Basal forebrain cholinergic neurons are particularly affected by the anticholinergic load of sustained PCP use. 4.5 Neuroprotective and antioxidant stack. PCP's combined dopaminergic, NMDA, and anticholinergic mechanisms produce substantial oxidative stress in the brain. The neuroprotective stack addresses this. NAC, already above, serving double-duty glutathione precursor providing brain antioxidant support. Alpha-lipoic acid, 300 mg morning, away from food blood-brain barrier crossing mitochondrial antioxidant. Relevant for the metabolic stress of PCP's complex receptor disruption. EGCG, green tea extract, 400 to 800 mg morning. Same NMDA-related neuroprotective evidence as in MDMA recovery, antioxidant protection for neurons during receptor system recovery. Cmax peptide, intranasal, week 2 onwards. The compendium Cmax entry, BDNF and NGF upregulation, cognitive enhancement, prefrontal cortex support. For PCP recovery, where prefrontal BDNF suppression from prolonged NMDA antagonism may be the most significant persistent cognitive impairment, Cmax is the most targeted available intervention. 4.6. Sleep architecture. The insomnia of PCP cessation has multiple simultaneous drivers: NMDA rebound, glutamate hyperexcitability disrupting sleep, dopaminergic stimulant crash, the same disrupted sleep as cocaine/meth cessation, anticholinergic rebound, cholinergic overactivity that contributes to REM disruption, and ongoing psychosis if present. Quetiapine, 25 to 50 mg prescription, physician guidance addresses sleep, anxiety, and the psychosis dimension simultaneously. The most useful pharmacological sleep tool for acute PCP cessation where psychosis is also present. Magnesium glycinate 400 mg plus glycine 3G plus melatonin 0.5 mg, the standard sleep stack from the compendium, non-pharmacological support once quetiapine is being tapered. L-theanine 200 mg evening, reduces the NMDA rebound cognitive hyperactivity that prevents sleep onset. Sonic protocol, delta binaural beats, 0.5 to 4 Hz, 60 to 70 BPM maximum, warm acoustic textures. The dissociative withdrawal sonic architecture from the compendium. No sudden dynamics. No music associated with PCP use. 4.7. Peptide support. Section 5, the PCP craving, understanding and interrupting. Classical building the centurion, the dual craving, dissociative escape and stimulant intensity, both simultaneously. PCP cravings are the most complex in this guide series because they are the product of two simultaneous craving architectures that most frameworks address separately. The person craving PCP is simultaneously craving the dissociative escape, the NMDA mechanism that quiets the ordinary self, and the stimulant intensity, the dopaminergic arousal that makes the ordinary baseline feel insufficient. Both must be addressed in the interrupt. The PCP craving interrupt, 5-minute protocol. Name which craving is firing. Dissociative escape, need for the quiet, the disconnection, the pain relief. Stimulant intensity, need for the arousal, the power, the loudness. Both simultaneously. The name determines the parallel response components. High-intensity physical interrupt first. Sprints, push-ups, cold water. This addresses the dopaminergic stimulant dimension. The warrior needs a real signal before anything else can be effective. Do not skip this step. For 7-8 breathing after the physical, 6 cycles. The NMDA rebound anxiety that co-occurs with the stimulant crash requires vagal brake activation after the physical intensity step has provided the dopaminergic signal. Take NAC, magnesium, and tyrosine. Addressing all three dimensions, NAC for NMDA glutamate homeostasis, magnesium for NMDA channel modulation, tyrosine for the dopamine precursor supply. Contact. PCP use is often social and geographically specific. The person, the place, and the substance form a conditioned unit. Contact with someone outside that unit provides social interruption of the conditioned context. For pain-driven craving, execute the pain management plan. The complete analgesia of PCP was real. The recovery must provide a real alternative. For psychosis residue craving, take your prescribed antipsychotic if applicable. Name the phenomenon clinically. This is PCP residue in my fat tissue being metabolized. It will diminish. More PCP will extend it. Section 6, porting the addiction, building the dual natural architecture. Classical building the centurion, two architectures must be built simultaneously, because PCP was doing two things. The compendium C28 substance masking analysis produces a dual signal for PCP, the dissociative escape, same as ketamine, DMN suppression, pain relief, the quieting of ordinary self-referential consciousness, and the stimulant intensity, same as cocaine and meth, the warrior's need for genuine arousal, the flooding of the reward circuit beyond its ordinary reach. Both must be addressed. Neither alone is sufficient. Track 1, the dissociative escape architecture. From the ketamine guide, applied identically here because the NMDA mechanism is the same. Meditation, absorption states the most direct natural access to DMN suppression. Daily practice. The ketamine guide's contemplative tradition framework applies. The compendium, the progressive states of meditative concentration access flow through the deliberate application of sustained attention to a worthy object. NSDR/Yoga Nidra, the hypnagogic state between waking and sleep. 20 to 30 minutes daily. The closest non-pharmacological equivalent to the quieting of consciousness that NMDA antagonism produced. Holotropic breathwork produces genuine altered states through CO2/O2 balance. Non-chemical access to the territory PCP was opening through receptor blockade. With trained guide. Nature immersion and awe, the DMN suppression that genuinely large-scale natural environments produce, mountains, ocean, open sky. The ketamine guide's awe practice applies directly. Pain management, if pain relief was primary exercise-generated endorphin analgesia, physical therapy, magnesium's NMDA pain modulation, low-dose naltrexone for pain conditions. Track 2, the stimulant intensity architecture. From the cocaine, meth, and crack cocaine guides, applied to the dopaminergic component of PCP. High-intensity competitive exercise, vigorous training with genuine stakes. The warrior's dopamine requirement is real and requires real intensity response. The natural dopamine generated through genuine physical challenge addresses the DAT inhibition component's recovery. Competition in any domain, the social stakes dopamine of genuine competition, sport, business, creative, martial arts. Genuine risk, genuine reward. Mastery at the skill frontier, sustained engagement at the challenge skill edge. Flow state dopamine through creative or technical mastery. Service, the sustained meaning and dopamine-oxytocin combination of genuine contribution. For the PCP recovery population, often concentrated in communities affected by violence, poverty, and the same structural conditions that made PCP available, peer recovery support and community service are particularly meaningful applications. Track 3, the acetylcholine restoration architecture. Classical building the centurion, the third track that no other guide requires, because no other substance has the anticholinergic dimension. The acetylcholine system that PCP was antagonizing is the primary system for memory formation, executive attention, and the specific quality of cognitive clarity that the anticholinergic load of PCP was impairing. Building access to acetylcholine-mediated cognitive states through natural means. Deliberate memory practice, the explicit engagement of episodic memory, journaling, storytelling, remembering specific events in detail, activates the cholinergic circuits in the hippocampus and prefrontal cortex that PCP's muscarinic antagonism was suppressing. Sustained attention practices, reading long-form material that requires sustained attention, not social media, chess, any practice requiring extended focus without breaks. Cholinergic circuits are the substrate of sustained attention. Practice rebuilds the system. Dietary choline sources, eggs, liver, fish, legumes, the dietary precursors to acetylcholine production. The recovery diet should include choline-rich foods alongside the alpha-GPC and CDP choline supplements. Physical coordination and skill learning, new motor skills require intensive cholinergic circuit engagement. Martial arts, dance, musical instrument learning, any motor skill with genuine complexity builds the acetylcholine system through use. Section 7, Navigating the Recovery Kernel, Your Protocol Map. Section 8, The Medical and Community Context. PCP occupies a specific historical and community context that clinical medicine has largely failed to address adequately, mirroring, in some respects, the failures the compendium documents with crack cocaine. 8.1 The Community Dimension. Classical Building the Centurion, the compendium's crack cocaine framework applied here, punishment substituted for medicine. PCP's epidemic periods, the late 1970s and 1980s, with regional resurgences, disproportionately affected urban, lower-income, predominantly black communities, particularly in Los Angeles, Washington, D.C., Philadelphia, and Detroit. The treatment system's response to PCP misuse in these communities has historically prioritized law enforcement over medicine. The specific failures, treatment specifically for PCP use disorder is rare even now. Most substance use disorder programs do not have PCP-specific protocols. The CYP2B6 dissociative logjam that determines why some individuals experience prolonged, severe PCP psychosis is rarely tested in treatment populations who need it most. The cognitive consequences of heavy PCP use, the prefrontal and cholinergic impairment that affects employment, relationships, and the capacity to engage with recovery programs, are rarely addressed clinically. The recovery kernel's position, stated plainly, the person who developed PCP use disorder in conditions of poverty, community disruption, and inadequate treatment infrastructure was not failed by their own constitution. They were failed by systems that chose enforcement over medicine and that, when medicine was offered, rarely offered the medicine that the specific pharmacology of PCP required. 8.2 Co-occurring conditions common in PCP recovery. PTSD. Trauma is extremely common in the communities most affected by PCP and in the experiences that PCP use disorder develops within. The dissociative and analgesic properties of PCP specifically buffer trauma symptoms. PTSD treatment is a concurrent recovery track. ADHD, the DAT-mediated stimulant component of PCP may have been self-medicating genuinely untreated ADHD. Evaluation and non-stimulant treatment, atomoxetine, guanfacine, are appropriate where ADHD is confirmed. Tobacco/nicotine, PCP is predominantly smoked in the wet/sherm form, usually on tobacco or cannabis. The nicotine dependence that co-occurs with PCP smoking requires its own treatment, varenicline, NRT, or bupropion. Note CYP2B6 metabolizes bupropion, the same gene as PCP. Metabolizer status affects bupropion dosing significantly. Cannabis use disorder. Many people who use wet/sherm use cannabis as the base rather than tobacco. Cannabis co-occurring with PCP use disorder requires evaluation. 8.3 Clinical resources. SAMHSA Treatment Locator, find treatment.gov or 1-800-662-43574 General Substance Use Disorder Treatment. PCP-specific programs are rare but some urban addiction medicine programs have specific experience. Psychiatric emergency, if prolonged psychosis, crisis evaluation at any emergency department. Specifically name PCP as the substance. CYP2B6 testing, through any clinical laboratory or pharmacogenomic testing service. This is the single most actionable genetic test in PCP recovery and one that most treating physicians will not think to order. Crisis, 988, Suicide and Crisis Lifeline, 911 for medical emergencies SAMHSA, 1-800-662-4357. A final word. Classical Building the Centurion, the clarity was real. The instrument was borrowed. Recovery is owning it. PCP is the hardest substance in this guide series to write a closing for, because it does not fit any single story. It is simultaneously the substance that provided the most pharmacologically complete escape available, NMDA analgesia that blocked every kind of pain simultaneously, and the substance that produced the most publicly visible and most misunderstood behavioral profile of any substance of misuse. The person who used it was not the person the public saw. The Compendium C37 framework asks, what was the substance providing? For PCP, the answer is complex and honest. It provided the silence of NMDA receptor blockade, the intensity of dopaminergic flooding, the perceptual distinctiveness of sigma-1 activation, and the anticholinergic blunting of embodied stress. All four, simultaneously. Nothing else in this guide series does all four at once. That combination was seeking something real. The silence from unbearable noise. The intensity that the baseline never provided. The pain relief that the body never generated adequately on its own. The perceptual distinctiveness that ordinary consciousness denied. Recovery is not denying that these needs were real. Recovery is building direct access to what was being sought through means that do not produce prolonged psychosis, do not accumulate in fat tissue and re-emerge weeks later, and do not require the person to become invisible to a healthcare system that never developed a treatment for what they were experiencing. The meditative silence is real, and accessible through practice, without NMDA blockade. The intensity is real, and available through genuine challenge and competition, without DAT inhibition. The pain relief is real, and achievable through endorphin architecture and genuine pain management, without the analgesia that allowed injuries to go unnoticed. The perceptual distinctiveness is real, and accessible through awe, creative flow, and contemplative depth, without sigma-1 agonism. The compendium names CYP2B6 as the dissociative logjam gene. In PCP recovery, the logjam is not only pharmacological. It is the gap between what the person needed and what was available. Recovery builds the path around the logjam. The clarity was always real. The instrument was borrowed. Recovery is owning what was borrowed, directly, permanently, without interest paid in psychosis. Treatment locator, findtreatment.gov crisis, 988 SAMHSA, 1-800-662-4357 emergency, 911. Refer to the Recovery Kernel Complete Centurion Compendium and the Ketamine Guide for all referenced protocols. Crisis, call or text 988 emergency, 911 SAMHSA, 1-800-662-4357. How to recover from PCP using the Recovery Kernel Substance-Specific Navigation Series.